we are going to talk a little bit about the digital era that we are living in orthodontics. And basically what I prepared today is a comparison between the case that I use it to treat with fixed appliance, and nowadays I treat them with aligners. I do prefer to treat them with aligners. So the sequence of the lecture is basically case that I treated with fixed, and after the case that I treated, a similar case that I treated with aligners. More than this, we are living in this moment that we have the digital revolution, right? Not only in orthodontics, but also in orthodontics. And we can't be blinded that orthodontics will be immune to these things and to this revolution that we are living.
Chào bạn, tôi là avatar của bác sĩ đột chí buôn quê một bản số kỹ thuật số ôi in tốt dễ chạy hôn văn hiệu thôi gian dễ tổ chui en hôn tôi yêu trái dễ bạn dâu một diệu ghi ru đã sự tù bì hay hin xung quanh mỗi tu giang tay rồi các chung ta mua sam các chung ta hốc tham sĩ các chung ta yêu vang vuốt phai dày chúng ta giang song trong một cuộc cách mạng sốt tu su trong những vũ trí thế robot chẳng thuộc hiểm hậu tua tri tuyên han tàu chẳng thuộc x quang thuộc tiêu chẳng quan nguyên bác sĩ quan đến ông tôi sẽ đã kể ra để có cố sự ảo của sport và bên trái là rằng thì chẳng có wifi vậy thì tôi hôn bên tại sao chính hà là dùng người ngoài quốc khut trôi giả chế lúc chúng ta dọn han hung diệu môi mê tông minh hòn hay cũng cầm phá các công nghệ số cái chính là và cố sự học giảng thầy rồi thuộc để làm sang và các
So, as you can see, I can speak Vietnamese, right? But this is a video done 100% with AI. So it's like text-based, and we can do an avatar, talking anything at any language. And why we think that orthodontics will be different, will not be impacted by this that we are living. Okay, but this is not my comfort zone. I would like to highlight that aligner therapy, for me, it's not my comfort zone. My comfort zone, I grew up in the fixed appliance era. So actually, I decided to be an orthodontist because I like to bend wires, right? Until today, I really like to bend wires. And this was one of the main reasons why I chose it to be an orthodontist. But the evolution is here. And I need to step out from my comfort zone. So I need to understand more about aligner therapy. I selected few cases in this beginning that will show you, the idea is to show you how I feel comfortable treating cases like this with fixed appliance, right? This is a difficult case, a trend of class 3 vertical patient in which we planned the intrusion of the lower incisors together with the retraction. With the posterior anchorage of that, we added a pontic there. And so we did this mechanic with an utility arch plus power chain to do this retraction. And after 2.5 years of treatment, it was a long treatment with slow movements, we got this clinical result. So this is a situation that we feel very comfortable. We tried to get the roots inside the bone, and we did it. Another situation with fixed appliance, we have in mind very clear the strategies to treat our patients, the tactics, what we can do. For example, in this case, the patient has a little bit of canting. So we decided to put a TMA and to bend this TMA with an anti-curve and to tie with its stainless steel only one side, trying to do the intrusion only in this side. That's the mechanics. And so we continued with the utility arch in the upper and the lower. Here we did it like a segmented bonding. We didn't bond the canine at first, so you can see that canine is very displaced occlusally, upper and lower. So we tried to avoid in the beginning the side effect of this distal tilt of the canine. So we did first the intrusion of the incisors, and after we bonded the canine, and now we have the wire here doing the anchorage, and we are doing only the movement of this canine. But we need to change, right? That's the reflection of the factors that made me change along my orthodontic life. The first factor that made me change is to understand the case that I can do properly with aligners. And this is about 2 points. To understand the nature of the malocclusion, it means if this is a skeletal malocclusion, for example, a skeletal class 2 or a dental class 2, this means a lot. If the patient is growing or if this patient is not growing, so the nature of the malocclusion, our diagnosis. But also, what is a little bit different, we need to understand the predictability of the movements that aligners can provide us. So sometimes you have some movements that are not so predictable, and they can make the case be a little bit more difficult. Look, this case we treated a long time ago with fixed appliance. And I have a good position of the roots. So when I have a good position of the roots in the sagittal or in the transversal, I know that this case tends to be easier to be treated with aligners, right? What we did? We did a jig here, a TED, we did the distalization, and we got a good clinical outcome, right, with fixed appliance. One of the advantages, talking about the advantages of the aligner technique, for this case, for example, that I want to avoid the movements of the incisors, it's only to plan distally the absence of movement. So it's much easier for us. So I see it as an advantage, the control of the incisors, upper and lower incisors, and also the literature is saying us that yes, you can control better lower incisors with aligner therapy. What you can do in a different way? Doing the same in a different way. This is a class 2 subdivision, quite similar. I think that's a little bit worse in this case because it's almost full cusp, right? But it's dental. The apex is not so bad. Basically what I need to do is the sequential distalization to put the canine in position, and after correct the lateral and also the anterior region, especially the deep bite. Remembering that, okay, I have a good position of the roots. The apex is, I like to say that the apex are in class 1, but the roots are not. What you tend to do, what you want to do, distalization, sequential distalization, and after gaining space for placing the canine and incisors in a good position. The digital setup for this case. We started by sequential distalization. We added an engager in the distal of the molar, because this is the region actually, if we do the distalization, the region that tends to be mistracking more is the distal region of the molar. So that's the reason we added the engager in the molar in the distal. And you can see that there are not a lot of engagers. That's a characteristic of the aligner, which has the trim line above the zenith, right? Because I have much more retention, much more adaptation, so I don't need a lot of aligners. I tend to use maximum 3 aligners per quadrant. That's what, like, my rule that I tend to follow. We continued the treatment. Now we are planning to use elastics, class 2 elastics, so we bonded buttons in the canine. We need more dental effect on that canine, so we are planning to use buttons and elastics. And finally, we are finishing the case. Right here we are finishing the case. The attachments, the engagers to promote extrusion in a finishing phase. And that's the case finished, good class 1, and we decided for retainer fixed, retainer upper and lower. So, if I understand the complexity of my treatment, not the complexity of my diagnosis, not only the malocclusion, remember, the malocclusion plus the complexity of the movement. So, if I understand this, that the moderate and the easy cases I can treat only with aligners, but the difficult case, maybe I need some hybrid mechanics, this is something very good that I can have in mind from the day number 1. Well, I did like a game, right? Trying to put side by side the situations that I showed you here. So that's the sequence of the lecture. The game is like this. We are going to show you this ortho card game. Okay, this is specifically made for the comparison of these two treatments. Look, molar distalization. If I want molar distalization with moderate difficulty, as we had in the first case with fixed appliance. This is the card for the fixed appliance. It was a good predictability. The treatment was a bit higher when compared with the aligner therapy. This is true, this occurred. TEDS, we use it, and the journey of the patient is associated to the fixed appliance, so it's like moderate. The advantage of the aligner would be, in this case, the case was a little bit more difficult. We got a little bit less of time, and the patient journey was easier. And look, the tips here is to use elastic plus sequential distalization. So for this case, this type of case, we have two strategies, two possibilities, but we can think that for sure, if I take this type of case in my office, I will try to treat with aligners, with clear aligners, right? Okay, the second point, mastering biomechanics. So we start to understand biomechanics and to have more confidence in your treatments to make predictable movements. Again, a case that I treated with fixed appliance. We planned here to increase a little bit this leeway space in the upper to promote a super class 1, and after to retract the lower and the upper, in the upper, to promote a little bit more of retraction, right? The patient has a bit of biprotrusion. So that was the plan. In the upper, I used a head gear, and after a transpalatal arch, and in the lower, I used a lingual arch. For retraction, as we did with ceramic brackets, I decided to put, because of the friction, I decided to avoid the sliding mechanics, so I added this arch with the loops. That's the evolution of the case, and we finished the case. Okay, that's good. The case with aligners, it's a bit different, but the principle of anchorage, simple anchorage, it's quite similar. The idea here is to compare the type of anchorage. The first, when I do need minimum anchorage, okay, this is a good case for aligners. If I need a lot of anchorage, for example, extraction case, I start to think with hybrid mechanics, right? And all the times I will be transparent to my patient regarding to this. But in this situation here, we planned the distalization of the molar and lingual root torque of the upper. I don't want only proclination of the upper. I want lingual root torque of the upper. So that's the biomechanics. We added one TED here. Why? Because if I check that these incisors are proclining that much, I will put an elastic. If I want to leave them to procline, okay, I remove the elastic. So I can control it along my treatment. The retraction, that's the plan. Remembering that about biomechanics, the way that I have to play my force over the grounds is about the digital setup. And about the digital setup, I have three main pillars: the staging movements, the way that the schedule of movements, where I'm going to place attachments, and also the working setup, the final position, the overcorrection, the over-engine. That's important too, as we do in orthodontics, right? If you have a deep curve of spin in the lower, what we do? An anti-curve, right? And that's the same. It's wrong to think that the digital setup is like the final position, very beautiful. No, we need to over-engine the movements also to get the proper force in the grounds. The mechanics with the elastic. So we are doing the sequential digitalization here. Few engagers. That's the digital setup. You are going to see, even the third molar, look the third molar here. We did the digitalization of the third molar. Because of personal reasons, I would need to extract this and this. So we decided to start trying to digitalize. And did you see that the amount of root torque that we played here in the incisors? A lot of root torque, right? Difficult movement, one of the worst movements for, not only for aligners, right, in orthodontics. A lot of bone to promote resorption. So, that's the evolution of the case. Here the patient is placing the aligner with the elastic. After 10 months of treatment, we have this midline correction. The premolar is placed in position. First day of the patient trying to put the elastic, very easy. After they start to do with the hands, right? Okay. And after 18 months, we finished the case. The deep overbite is corrected. The class 2 corrected. We bonded. We felt so comfortable here that we have the palatal side of the upper incisors touching the buccal side of the lower crowns of the incisors. So it's doing the retention by the buccal side. So we decided to bond a 0.6 wire only in the canines, SS. And in the upper, I tend to use, in all my cases, the aligner retainer, right? With the trimline above the zenith. But very nice result. The card game. Let's check about the anchorage. So the case that I have minimum anchorage, right? As the first case, with mild difficulty, I had a good efficacy, but I used the headgear and TPA. Maybe this was the worst part for, especially for the patient, right? Not for me, but mainly for the patient. But both cases I can treat with aligners or with fixed appliance. The advantage here, okay, I used TADs, and the strategies, the tips would be to use the strategies as synergistic movements. In this case, synergistic movements means to procline the upper, right, incisor and together to do the distalization. We are using like the concept of reciprocal anchorage, what's very good, like when you do the expansion, the bilateral expansion, or even if you do only one side expansion, you are going to have this reciprocal anchorage. So this is when you can combine the synergistic movement, it's very, very good, as this case. So for these situations with minimum anchorage, once again, I tend to consider aligners as a very good option. If I need more anchorage, so I tend to think about other possibilities too. Well, the third factor is that I'm not going to throw out all my knowledge that I got from orthodontics. So I need to be aware and I need to be wise and try to apply this knowledge in aligner therapy, right? For example, if I want some orthopedic effect, this is a nice study of Dr. Sevidantes showing us how the premaxilla and the zygomatic area, they move forward, or even the lips and the cheeks, they move forward when you use the face mask. So if I want this orthopedic effect, I will need to wear a face mask, rapid palatal expansion and face mask. But what I do in the lower arch, in this case. So nowadays I have a lot of cases that I like to use the aligners in the lower. For this case, I use it only the face mask, right? So we have here in the beginning, during the treatment, and at the end of phase 1. But what we can do in a different way, doing the same in a different way. Look this patient, this is a pseudo class 3 patient with retroclination of the lower side. So she has the premature contact and she's displacing forward the mandible, as you can see here, right? But also she has some characteristics of real class 3. So she has deficiency of the maxilla. The first approach, the first device that we used was this in-office aligner that we made. We published this technique in the journal Clinical Orthodontics. Basically, we do the inclined plane, and after we do the thermoformation of a plate of 1.5. And after 2 weeks, so this we published it for this case, but we use it also for this other case. After 2 weeks, we got almost an edge-to-edge relation, right? But we want more. We don't need to, we can't leave this patient with an edge-to-edge relation, right? We need to do the traction of the maxilla. So we decided to, in this case, we published 2 in the journal Aligner of Orthodontics. So we did the palatal expansion, hooks, and for me, one of the great advantages of wearing aligners during this case of traction of the maxilla is this that you are seeing here, right? Is the elastics used together. I mean, together. If she's wearing the face mask, only the face mask. But when she goes to school, she will remove the face mask and she will wear the aligner plus the class 3 elastics. Important. There is a trend to this aligner be displaced, right? Be displaced forward. Natural trend. Look here, this is a study published by Dr. James Ma that shows us the difference of retention when you have the trimline above the zenith or scalped trimline. Look here, without engagers and with engagers. And the question is, where do you want to be when you are thinking about aligners and elastics? For sure, I want to be in the green group, right? The trimline above the zenith. The blue one is straight trimline in the zenith. And that's the result that we got in phase 1, right? So the initial. Here we have like the final of the phase 1 and pre-phase 2. So the idea is to transform our knowledge, right? To take our knowledge from fixed appliance also and to apply this knowledge in the clear aligner therapy. Playing the game of the cards for these situations, and I selected these situations when I'm doing, specifically, when I'm doing the expansion, rapid palatal expansion, the upper, and I do need to decompensate the lower. So that's very nice to use the aligners. In the past, I used it to use or a lip bumper or a removable appliance in the lower. Nowadays, 100% sure that I do prefer to treat the lower arch with aligners, right? But the main advantage for this case, for me, is this one. The need in the face mask, this patient needs to use the face mask to do the traction of the maxilla. And when we check the aligner therapy, so this patient can wear also the aligner in the lower plus the elastic. So you keep pulling forward the maxilla all the time. And once again, for this case that I'm treating with orthopedic palatal expansion, the upper, and I do need the compensation of the lower, so I will go for the aligner therapy in the lower. The fourth factor, considering complex case, and this maybe could be like the missing link for aligner therapy, right? When I do need a lot of anchorage control, when I do need a lot of torque control, extractions case, complex case, root movements, upwriting, mesialization of the molar. I could talk about different situations that we do require a lot of mechanics to provide these treatments. For example, this case we treated with fixed appliance for extractions. Straightforward, right? I mean, biomechanically, you extract premolars, you decide the type of anchorage, if you want to lose, depending on the profile of the patient, if you want to retract more or to lose more anchorage, you do the retraction. This was a case that we worked with the type B anchorage. We allowed the posterior mesialization, so we didn't work it with any type of appliance in the posterior region. So fixed appliance reaching a strong SS wire in the upper and the lower. This is very important, and this is actually another advantage of the aligner in my point of view, that I can start the retraction from the day one, because I have the control of the region of the incisors. So if I plan like some TED to keep the anchorage, I can start the retraction from the day one. Retraction of the canine, and after, as we are using metallic brackets, we applied the sliding mechanics for retraction. We got this result. Okay, so what we can do in a different way. Look, the case is quite similar, right? Maybe it's a little bit more difficult, the case. So we have the crowding the upper, crowding in the lower. Class 1, we are going to work with the extractions and TEDs, right? The TEDs, the idea of the TEDs is to control more the anchorage. Important factor that we have here, look the roots, especially in the upper arch, in the lower left arch, left side. Maybe we will struggle to keep this parallelism of the roots with aligners, right? So for these patients, what I talk for the patient, look, because this patient only is willing to have the treatment with aligners. She's not willing to have the treatment with fixed appliance. So what we are going to talk is, okay, we can do with aligners, but maybe I will require some hybrid mechanics to provide you the good finishing with a good parallelism of the roots. That's what I talk. So if I need to do it in the middle of the treatment, to put some brackets, to bond some brackets, she already knows. It's different if I don't talk anything for the patient and in the middle of the treatment, I do need to bond. It's much worse, right? Because it's like an excuse. Okay, it's not working with aligners, but now we need to bond brackets. And I came here to do my treatment only with aligner. But she accepted to do the treatment and, if necessary, to bond the brackets in the middle of the treatment. The strategy was so to perform the retraction of the upper and the lower. We know that the aligner therapy, we tend to lose more torque and to lose more anchorage. So the bow effect will be increased. What we try to do to avoid this bow effect? To put like large engagers as large as possible in the regions besides the extractions, like 4 millimeters engagers with 1.25 depth, right? This is what we can do. What else we can do? We can overcorrect over engines movements. What would we do in the fixed appliance? What's the natural biomechanics in the fixed appliance? Resistant torque, right? So you can, depending on the case, you can start the retraction, and along the retraction, you can play the torque in the wire to control your tip light. Exactly what we did, right? So in the digital treatment plan, we tried also to keep this torque. And again, trimline, very important to have cervical force here. Because if not, this movement is not going to occur. If you go for the most part of the literature in orthodontics, the authors are working with the trimline, scalloped trimline. And they say that the worst movement to perform with aligner, the less predictable, is the torque, the root torque, right? But with the trimline above the zenith is a little better, right? It's a little better. But maybe we are going to need hybrid. This is a nice paper that talks about strategies to avoid the bow effect, right? If you take the picture, you are going to check this paper that talks about the strategies to avoid the bow effect. And it's mainly like placing engagers, to over-engine movements, to stage movements also. I'm going to show to you the setup. It's very important to stage the movements. Look, this is the setup. This is very important. This space opening between the canine and the lateral. Why? Because once you open the space between the canine and the lateral, you allow the plastic to fill that region. And once the plastic fills that region, all the force to promote this retraction of the canine will be in the mesial surface of the canine. Right? It's different. For me, this is more important than the engager, the attachment. Much more important. Why? Because the biomechanics is different. With the brackets, I have the bracket here and all the system of force in the buccal. With aligners, no, right? The engager there, it's only something that it's holding, but very soon it's not be holding anymore. My main system of force relies on the penetration, the fulfillment of the mesial surface of the canine. That's the most important. And this is the reason why some papers are showing also that for the molar distalization, we don't need engagers. Some studies with finite element model. Why? Because the biomechanics is different. We need to make the plastic fulfill the mesial surface of the molar. And again, look the difference between the force distribution when I want torque, if I have the scalloped trimline, or if I have the high and flat trimline. This is also one study that was published years ago, but look, much better, right? It's difficult to promote torque only playing this force in the incisal region. So the trend is really to lose torque here, and it's not 100%, but it's better. The evolution of the case, so we have this situation, and what we are seeing here, what can you see about this space closure? This is the typical space closure only with aligners. Let's be very honest, right? We have like difficulties to bring big roots. Very difficult to bring big roots. So we have the tilting of the crown over the space. The best region that we have is this region here. That the canine was initially with the apex in a good position. So mainly, I had here the tilting of this crown. That's the reason why it's better. This one here, this side here, we need to do something. This side here also, in the upper arch. So at this point we did a revision to close these diastemas, few diastemas that she has. You are going to see that there are some IPRs. In some moment here, these red arrows are IPRs. These are ghost IPRs. We didn't made it clinically, only digitally, just to keep more force to close these diastemas. This is the result. Oh, look. At this point, we decided to bond brackets, ceramic brackets. Here is like, it's metallic, right? But we decided to bond brackets. So we decided to bond these brackets with the expression of the root position. And when we are doing the leveling, we are doing the movement of the roots mesially, right? We are trying to make them more near. We reached the TMA wire, and with the TMA we did a V-bend to bring the roots. And so after these mechanics, we achieved these results. This side is very good. We could finish the side, but the other side you are going to see that there is an open bite, a little bit of open bite, especially in the region of the first molar, the mesial ridge of the first molar. Look this open bite. We need to work. I can't finish this way, right? Let's check what we need to do. Basically, I do need to extrude, and this is an advantage of the digital. I can understand exactly what I need. I need to extrude more the mesial ridge. What's the mechanics again? We went for the mechanics. This is the clinical situation at this point. And again, right? We molded few brackets. Here is actually it's a double tube. SS1825. And NiTi, we started with the NiTi 0.12, and plus elastic, trying to extrude this mesial ridge. That's the purpose of this finishing phase. It's the only thing that I need to do to finish my case. So this was the result that we achieved. This side is 100%, midline on. Even the recession is a little bit better. decide, okay, you can say, okay, there is a free occlusal space, but also she needs to do some restoration there. So we consider it like a good final result. And about the parallelism of the roots, let's check what we have in the OPG. Good parallelism, right? Broadly speaking, we have a good parallelism. I think that the worst side is this maxillary side, but it's reasonable. We can finish the case. And let's check how is our torque, right? How is the profile? Because the chief complaint of this patient was the profile. In the middle of the treatment, okay, in the middle of the treatment, and at the end of the treatment. Good profile, the patient was satisfied. I was satisfied also with this lateral view of the lateral ceph, right? So we finished the case this way. So we need to understand that for this complex case, yes, we expect the best, right? We plan in the ideally way, but we need to also to be prepared for the worst scenario. That would be to use the hybrid mechanics, as I showed you before. And about our card game, who will win this card game? Look, for difficult case that I need translation for space closure, is it easy to promote only with aligners? You could answer me, oh, depends on the position of the root. If I have extraction case in which the roots of the adjacent teeth are in a good position, okay, we are going to be able to close the space very well. But if I need translation movements, right, I need to move the crown and the roots at the same pace. So the fixed appliance tends to present a very good predictability. We have the disadvantage of needing to reach a stronger wire to start the sagittal movements, right? It takes time sometimes. And even in the beginning of the treatment, you can proclaim incisors, for example, if you have some crowding. But compared to the great predictability, it's much more interesting to have the fixed appliance, right? Because in this situation, it's not predictable with aligners, these translation movements. So for this game, for these two ways of doing the same, we consider that, yes, the fixed appliance wins the battle, and we should at least be transparent with our patients and talk that maybe we will need some hybrid mechanics to close this space, right? And this is applicable for all the cases that you need a lot of root movements, right? Even if I have other factors like brachycephalic patients, that will make our treatments more difficult. At least this is the way that I tend to do in my office. So the joker, what's the joker here? The aligners lost the game, but the joker, and it's interesting, because the worst scenario for us is to bond fill brackets and to do hybrid. And so I come back to the beginning of the presentation, of my comfort zone. So what I always say that for the orthodontists, the worst scenario that we have to treat difficult cases with aligners is to do a little bit of hybrid. So it's easy for us, we like to do it. right? So I feel very comfortable also treating difficult case with aligners. And finally, the last factor that made me change, right, along these years to the digital process and to the aligner therapy is that we believe that we are only starting, right? We are starting the curve, and more we are going to evolve. For example, I can interact with doctors along the world during the treatment, the ortho diagnosis. I use it in the beginning of my career. I use it to keep the photos and the model, the cast models of my patients. I would go for the house of one of my professors, right? Nowadays I can do it with a doctor from another part of the world, as we are doing. This is an app that I have devised, and it gives you the idea of the treatment complexity. It's not the case complexity. It's a combination of treatment case complexity and movement predictability with aligners. So it has some questions about the predictability and the strategies that you are planning to use, right? So if you take a picture, you are going to see that. Also, after the diagnosis, we can go for the treatment plan digitally through a digital interaction. And also nowadays you have the possibility of doing the patient monitoring through AI, right? So you can see that this is all a digital process. This is a nice software that provides us feedbacks about the case evolution, the tracking, the movement, even the hygiene of the patient, a lot of factors that we can customize. And finally, we get this result. This is a patient, for example, that I never saw in my life. But I helped a doctor from Croatia to do the diagnosis and the treatment plan and the case follow-up. So I believe a lot in this process, right? In the digital process, reaching real results. But if I take, for example, a case of 4 extractions, I'm not able to do this process, right? To give you, okay, because so it relies a lot on the doctor. But if I take a case with mild or moderate complexity that I can recognize from the beginning, so yes, I'm sure that I will achieve a good result. And this doctor also will achieve a good result. So what are our final thoughts? Why? Why, as we mentioned it in the beginning, the idea was to provide you the whys, why I had changed from brackets to aligners. And it's very simple, right? Basically, because in the end of the day, what matters for us is our patient. And what I see is that I can get excellent clinical outcomes with aligners, and also I can provide them a smooth treatment process that more and more they are looking for it. So this was the reasons why I do believe that more and more we are going to apply the digital process in our specialty. And the factors, as we mentioned, that made me change along the lectures, understand the diagnosis, the biomechanics, the translation of knowledge, the troubleshooting for complex case, and also take advantage of the digital process. So these are the whys I had changed. Well, these are my contacts. Once again, it was a great pleasure to be with you today, and thanks for your time. And I hope that, I always say that in the end, what we want when we are in a congress or in a lecture is that this knowledge could impact your clinical life somehow. That tomorrow when you come back to your offices, you remember, oh, Gabriel talked about it, maybe I will try to do it, that's a good idea, that's a bad idea, but somehow you could remember the case that I presented today. So thank you so much for the time, and I wish that we could meet in other opportunities.
Thanks a lot for a very interesting and very informative presentation. So I would like to invite you to stay on the stage for the certificate and a thank you gift from VIO.